Okay, we are live now.
Hello and welcome to the day two of second edition of Global India Healthcare Conclave. We had a very interesting, amazing session throughout these 2 days, and now we are on the last session. Very interesting sessions, be it the post-COVID era healthcare management, compassion, technology, various other aspects covering the healthcare system in India and across the globe. And now we are uh, joined by some eminent speakers from across the country, and that too on a very important topic, that is how is this COVID-19, this new era of pandemic, is impacting the cost management for healthcare industry. We'll try to touch upon the challenges, what has been the opportunity, and what would be the way forward. My name is Sudhir Gautam. I'm the editor with the APAC News Network. This particular second edition of Local India Healthcare Conclave is organized by APAC News Network, iLog Media, and various other government of India and state governments have been our supporting partner. We are thankful to the Digital India. We are also thankful to the NIC, National Informatics Center, and also the Department of Science and Technology with the Government of India. So let me welcome our speakers for this panel. Uh, we are joined by Dr. Prashant Deshmukh, who is the Chief Operating Officer of SIMS Hospital. Thank you very much, Dr. Prashant, for joining us.
Thanks, Sudhir.
And we are also
Yeah,
joined by yet another speaker from the Shalby Hospital, Mr. Shani Shah, who is the president with the Shalby Hospital. Thanks for joining us, Mr. Shah.
Thank you. Namaste. Thank you.
Okay. And we are also joined by the Chief Strategy Officer with Ujala Cygnus Healthcare, Mr. Pratik Ghoshal. Thanks for joining us, Mr. Pratik. So, with this, I would like to move forward with my first question. Now, uh, the COVID-19, a lot of discussion has been happening. So, one of the important aspect is the healthcare professionals, the healthcare management systems have to talk about their cost management in the COVID-19 era, and also how the patients who are receiving the healthcare services uh, think this is affordable. So my first question would go to Dr. Prashant Deshmukh. What would be your initial take on the cost management of healthcare industry? What has been the challenges, how you could cope up, and what would be the way forward? I would like to have a initial remark in the beginning from you.
sure. Thanks, Sudhir, for inviting me for this wonderful discussion. So, as we said, I think right now we are into 7 to 8 months into the COVID era, kind of, and we are handling that situation differently. And each hospital has gone through different turmoil. So, to start with, like first couple of months had been very differently impactful for every one of us. Occupancy was nearly down to 20 to 30% for most of the hospitals across India. And that scenario slowly changed when this COVID care was taken by many of the hospitals. And slowly that it's mainly because social responsibility and all. So that thing has changed, and now most of the hospitals are slowly coming back to their routine work. I guess, which we last time checked, by around 50% occupancies. That is still not at the same level which was used to be normal during this season. So right now, every hospital is facing major challenge for revenue, but yeah, definitely the cost is significant part, because if you can sustain this period, that will be definitely wonderful, because this will be the one of the industry which will come back very quickly to the normal economics. Maybe the top three industries, if you consider across India, across world, the hospital sector should be one of it to come back to their routine operation. The only thing is how well you can sustain yourself for maybe next. Right now, we might be into the phase of getting the routine work done, but as last 1 month news across globe is not good that the second wave is coming up. So we are not pretty sure what will happen in India also. So again, we might have to go back into the certain days where our COVID, non-COVID work specifically may again come down. So idea should be to optimize most of the thing, because if you really want to see, I will just differentiate this phenomena into multiple levels. If the COVID we see, it's a medical phenomenon. It never seen, never has been experienced in our generation. Like I think last pandemic which happened is in 1920. It has its own challenges in terms of nobody has a ready recipe for it, how to handle it. So in terms of medical also, we don't know what is the treatment. Last 4 5 months the system itself evolved, and now we are better placed in terms of treating the patient. Another perspective would be the social perspective, which we are seeing right now is the word itself, social distancing started on all aspect, but it's the culture and the routine human behavior. I think this social impact is much more huge and much more impactful. Some yet to surface, and some of the impact is already in place. Financial perspective, everybody is aware. I think we have gone through different patch when Q1 was at the highest loss, and the whole GDP of India is in the negative figure into 20s. So that's more true for all the hospitals across India, which we had seen for us is as a negative kind of maybe EBITDA or the bottom line. But yeah, still our target should have been the cash flow management. How we are going to sustain mainly from the cash flow perspective. So how much money you are able to get, that to our initial target was. Right now balancing that cash flow across would be the major. Psychological is tremendously right now impacting around the psyche of the treatment itself, that patients are not yet to reach the hospital. They are not ready because of the whole COVID scenario. People think that hospital जाएंगे तो COVID हो जाएगा. That is still basic premise in many of the areas. So travel across cities also is restricted in that way, because people don't prefer to travel too frequently now. Operation challenges has been for us, and that actually is one of the aspect which we'll touch in terms of how we could optimize our cost in terms of operational efficiency. How much is required, because as we are at 30% occupancy, I think most of the hospitals they close down half of the area. Some of them unfortunately has to touch the HR cost also, which is like human resource, which was the last resort for us also, but for a couple of months that also has been done. So optimal utilization of resources would be the key in terms of how many areas you are using, how many things you are using. You can talk to all the stakeholders where you feel that the revenues are not generated, and how those departments can be slowly come back to the routine work. So, and there are different challenges, but operational efficiency should be the key for us to sustain for that wave to pass.
Thank you, Dr. Prashant, for sharing those views with us. While there is a general perception that this is a time where healthcare industries, of course, in the beginning of the COVID era, it was considered a lot of challenges, but later, once the COVID care was open, it was being said that the healthcare industry is the only one that is, is doing well. So, anyways, now there are a lot of operational challenges. Of course, we agree. Pratik, I would like to please your take on this. Pratik, can you unmute your phone? I mean, say, yeah. Yeah, your computer is unmute now. Can you speak for a while? Yeah. Maybe can you disconnect and connect back? Yeah. Meanwhile, we'll move on to our next speaker, Mr. Shani Shah, who is the president with the Shalvik Hospitals. Mr. Shah, we would like to know your initial remarks on this cost management during this COVID era.
Sure. So thanks, Sudhir. Just a short introduction about Shelby Group for those who do not, know about us. We run 11 hospitals across India with over 2,000 plus hospital beds. Adding two more hospitals over the next 2 years, which will take our capacity to close to 2,500 beds. Uh, uh, we are a 25-year-old company in terms of our incorporation. Company was founded by Dr. Vikram Shah, who is chairman and managing director, and also an orthopedic surgeon by profession. So Shelby has the credit of controlling about 15% of India's market share when it comes to knee and hip replacements. And as we talk today, more than 60% of the revenues come from other specialties. So, all the other specialties have been picked up really well over the last 26 years. See, cost management, right now when COVID is going on, people are talking about cost management. But honestly, Shelby has focused on cost management and cost optimization since the beginning. And that is, I think, the main reason why we have been able to grow very rapidly, right? And essentially, when people talk about cost, they generally think that, how can we, kind of optimize the operational cost. But I would like to kind of uh, put it across four large, broad buckets. First is the capital expenditure that you're making, right? Now, capital expenditure, when you talk about, you're talking about land, talking about building, you're talking about medical equipments, right? You're talking about all three areas. Very important to optimize it across all these areas. You can't choose a location that is really really far off, that it doesn't have access to patients, but at the same time you cannot pay a bomb, because then your return on capital comes after 15 years, and that makes the project unviable. Similarly, even within medical equipments, you have multiple options, right? You have so many options, and it's very important that you choose the correct workhorse that you need, because at the end of the day, doctors love their toys, but you need to make sure that what you are getting is something that you can make enough return on that equipment, as well as it solves and serves the problem, because you don't want the situation where a patient comes to you and you don't have the machine. So that is your capital expenditure. Very very important to keep that low, so as to make sure that you are able to get your return on capital employed much quicker. Area number two is cost optimization in terms of your uh, revenues. So essentially, what are you using as products, right? uh, where do you need to use branded products, where do you need to use generics? I think that call every hospital has to take, and make sure that you are optimizing your costs there. The second area is also, and I'm sure a lot of hospitals today follow it, is to have a set formulary, right? And when you have a set formulary, you basically are making sure that you don't have, because see, you in a hospital you have 200 250 bed hospital, which is our model. You have 30 to 50 full-time doctors, sometimes 60 to 70 full-time doctors, and then you have, say, around 100 visiting doctors. Now if you have, and every doctor has their own preference in terms of the medicines they want to use, the surgical products they want to use, the consumables they want to use. And if you keep everything, that means that you store in lot of inventory, and the more the inventory you have, you are losing interest on that money. So again, very important that you have a formulary where you make your doctors comfortable, and you have a board within the hospital group where you have senior doctors who are part of that, so they can address the doctors' needs as well, because ultimately the doctors are going to be the users or the prescribers of for these products. At the same time, the management of the objective should also be achieved, so that you are not be able to kind of spend a lot of money on that. So inventory is another area, and the other area, as I mentioned, is really the fact that you need to bring in these cost efficiencies. Now, why is this, spoken about over the last 5, 7 years? We never used to talk about this 15 years back, 20 years back, 25 years back. And the main reason for this is that a large part of your payers today, are basically giving you fixed amounts. Like, there are packages for more or less everything. A large amount of work that we do is government work, that is, your central government schemes, state government schemes. uh, then you have all these insurance companies again, where your top line is largely capped. So whatever you make at the end of the day is going to be essentially from what you save, right? So that is the thought process, where you really need to make sure. And now, because of COVID, hospitals are using a lot more PPEs, a lot more of other surgical items, where the cost per bed has gone up, right? And we all know that most of the governments have capped the prices. So you have to make sure that you are able to balance these different things. And because at the end of the day, at least for somebody like us, so every hospital has some or the other investor. For us, we are owners, but we also have many public shareholders also, because and what they are going to look at, these institutions, is basically what kind of return are you making on your equity, on your capital employed. And that is the reason why this is extremely important in today's context, and it will continue to be that way. Because 15 years back, we used to have 75 to 80% self-pay patients. Today, that has come down to about 50%, right? And this is expected to further go down, because insurance penetration in India will continue to go up, right? So that is the thought process.
Thank you, Mr. Shah. Am I audible?
Yeah,
Yeah. Mr. Pratik, we would like to have you are the Chief Strategy Officer with the Ujala Cygnus. Your initial take on this cost management in the
right.
healthcare system during
Sure.
this COVID
I
era.
think I completely agree with what Mr. Shah said. And the main trend that we have seen is the shift in pricing power from hospital providers to insurance companies and institutions. So you have the insurance companies looking at the top 20% of the workforce, and then you have Ayushman looking at the bottom, and the middle part is the only cash paying patient where we can actually price accordingly. So as prices get fixed and as panels start ensuring that the prices are constant, the only way to sort of ensure profits and your returns is the only way to do is to look at cost management. And when you do that, then there are a couple of ways that I think everyone has been doing that. If I have to talk about in the COVID era sense, so we've personally faced two sort of phases in general. Uh, Initially, immediately after COVID, I think it's also dependent geographically. So we are located in four states: Haryana, Uttar Pradesh, Uttarakhand, and Delhi. So we've had different outcomes and different experiences across the states. So some states initially, the occupancy fall was much higher, where we started converting our hospitals into COVID hospitals. But in
Yeah.
the other places where the impact of COVID was not that great, there we have sort of continued with how we have approached it before. The electives, etc., hadn't fallen as much as we had expected. And if they did, they came back at least in 2 to 3 months. That's what we've seen in Haryana. However, Delhi, of course, being one of the major hotspots, we faced issues there. And the way we tackled it, obviously, I think most hospitals either now are looking at COVID care or non-COVID care. And we've converted a part of our Delhi hospitals into COVID care to ensure that we keep the flow of patients alive. Uttar Pradesh and Uttarakhand, I think, has been mixed for us, where the impact was initially much higher than what we'd expected. But with time, I think electives have now improved. This is October month is generally a season where medicine department does the best. So I think we are still slowly seeing increasing revenues from these departments and a slow increase in occupancy, which initially was around 30-40% level, coming back to the 50-60% level, which we usually tend to do. In that sense, in terms of cost management, as I said, I think three main things, and maybe we can get into it in a little more detail. I think to have the input costs rationalized, because salaries are just going to rise, inflation is there, and with that, to have prices capped, it becomes even more difficult. So to bring in efficiencies either through technology, through inventory management, as well as through manpower and more allocation efficiencies, I think we'll see margins improve slowly and steadily. But going forward, I think prices are only going to stay capped. And in fact, we might look at a more universal insurance system where even the middle class, which is currently does not have an insurance scheme per se available to them, slowly and steadily, we might see them coming under the ambit of the government capped prices as well.
Thank you, Pratik, for those inputs. Glad to know there is a slow and steady increase in the margins. Dr. Prashant, with this, I'll come to you. Mr. Pratik has set the context. So, does this mean compromising with the profit margin or sticking to the old model?
Yeah, like if you look into the hospital, I think means there is, if you new and old model, one thing would be always common is the patient first. Yeah. So as of now, like yeah, I would suggest like what we have experienced is as making a social responsibility or making financial sense. If you have to take COVID care, it has to be done in a good way. Like that is the key. Like means it will take time for us to go back to routine work in a non-COVID area, because there's a lot of reluctance, lot of things are happening, and people are not ready to travel yet, and yet there is some risk associated in the hospital also in terms of getting that care. So whole system is now getting tuned into it. Like if you look into perspective right now, we are into developing and designing the SOPs for the post-COVID patients. What will be the SOP for them, how they will be getting admitted, what are the treatment protocols, and if we really need to do some kind of procedures. Emergency work is definitely going on. But for the planned work also, we are into strategizing SOPs in terms of at what time the cases should be taken, what will be the protocol in ICUs, and mainly all things are associated with the safety of patients, safety of employees, safety of the healthcare workers all together. So whole strategy is running around it. So new model would be in terms of continue what you are doing. If you are really focused on non-COVID work, specifically the hospitals which are maybe 10-year, 20-year old, they already are 400, 500 bedded. They are feeling the major crunch in terms of managing their finances because they already were at very good occupancy of 60, 70%, 80%. Those hospitals are at 50%. So another segment of hospital is there which were new, maybe 2-3-year-old hospitals which were yet to reach the complete capacity to utilization. They were at 40-50%, but somewhere they got a boon through COVID care in terms of their occupancy is higher. So as of now, continue with the non-COVID work in parallel with, if possible, the COVID care. Yeah, and we have to, like as a hospital industry, our first job would be to first handle this pandemic in a good way. So once it passes, the routine thing will come back. But be ready for it. Use this time for keeping yourself ready in terms of standardizing your protocols, standardizing your SOPs, so patient safety is not compromised, and that will build a lot of confidence in the people coming in the hospital, because everything will run around that psychological attitude of patient or around safety, which is the safest hospital, which is the best and which is the safest. So that should be the strategy on it. Yeah.
Absolutely right, Dr. Prashant. We would like to hear from Mr. Shah. Yeah, your take on
Sorry,
this, Mr. Shah. We would
can you
like
repeat
to
the question?
certainly. We had this question because of this COVID era. Now, the slowly and steadily, I mean, say the it's returning to normal. The things are returning to normal in terms of revenue, in terms of the cash flow, but sorry, does this mean compromising with the profit margin or sticking to the old model way? We would like to know about this.
No, I think honestly, what we believe is that this is a phase which has struck all of us, and it is going to go away in a gradual way. It is not going to go away overnight. And I think whatever protocols most of the hospitals were following earlier for the non-COVID patients, I think we will continue to do that, because this is a once in a 100-year kind of event, and you cannot plan for it. And essentially, the good thing is that at least in the areas where we are present, we have been able to treat a lot of COVID patients. We have never been in a situation or a state where we've had to reject any patient or put them on the waiting list. So that's a good sign, and which also means that this is not gone in the European way, where most of the countries in Europe were even affected in a worse manner, because the hospitals there were full, etc. So we were never in that situation. Having said that, I think people have also realized that they need to kind of think beyond this, and a lot of elective work, as I think some of the other panelists were speaking, has been coming back. So people are coming back. People have started to go out. Of course, it has not happened to the extent of pre-COVID levels, but we do believe that over the next 2 to 4 months, I think we are very optimistic that things will be back to the pre-COVID levels. Because see, at the end of the day, it's very important that people visit the hospital on time, because that means when something is diagnosed earlier, the cost is less for the patient, number one, and it's less painful as well. So I think it's very important that people accept this reality, take all the precautions that they must, and as Mr. Deshmukh said, that the uh, clinical protocols also need to be very, very strong, so that that really raises the confidence of the patients who are coming for elective and non-COVID work.
Yeah, yeah. Thank you, Mr. Shah. Pratik, I would like to have your take on this.
Sorry, actually, I had some technical difficulties. If you could repeat the question once, it would be easier
Yeah.
for me.
So we were the point which Dr. Prashant also mentioned, and also Mr. Shah mentioned, is about uh, the the compromising on the cost part, the cost management part, whether it is going to work in the profit margin, or it's like sticking to the old model.
Right. I think so. The model is going to change going forward quite a bit, and as we've already seen, the costs have been rising for a while. In
Yeah.
terms of our prices are capped and our costs are rising, so it becomes even more difficult. I think the way to look at the new model would be to look at a couple of things that we are doing as an organization as well. Is to look at firstly technology in a big way, which wasn't done at least till quite some time back. And obviously, lately with the pandemic happening, there has been excessive focus on telemedicine and a lot of other technology-based
Yeah.
solutions for healthcare providers. And where health technology can play an important role, I think, in two ways: is not only to develop an alternate revenue stream. So a lot of people are looking at it in terms of developing an alternate revenue stream to have telemedicine, to have e-pharmacy, but also as a very efficient way of ensuring that your processes are optimized, your costs are leaner, the leakages are much less. I think there is a lot of play involved, and that can be utilized to a lot of good extent going forward. To give you an example, something like EMR, which was being implemented in a big way even before COVID, has been taken much more seriously today. But EMR, not just for data management, I think there is a lot of other applications that can help you to ensure that leakages are much less. If your EMR is connected to your pharmacy, if it's connected to your labs, it ensures a seamless system. And what a seamless system ensures is that there are much less leakages now. So embracing technology just not as an alternate revenue stream, but also to improve your efficiencies. I think that will be a very important step, because patients today, so we operate in tier two and tier three cities. Their needs are not very different from the patients of a tier one city. And lately, we have seen a trend where, due to COVID, patients have stayed back. Initially, they used to travel to lately that trend has been reversing, and we have seen now patients coming in to our hospitals at a much more higher occupancy level, leading to better occupancies, better revenue.
Yeah. We got the point from Pratik. As Dr. Prashant, I'll come to you. As Mr. Prashant said, it was the use of rationalization of technology for cost management. At the same time, he also mentioned about it as a alternate uh, a way of revenue stream for the healthcare system. So I would like to know to what extent in these the COVID, the ongoing COVID era, which has been more than 6 months now, to what extent your management or your administration has integrated the technology, and how do you look at this as an alternate stream? And it is also meeting the healthcare services that your administration, your management could provide.
Sure. Yeah, I think one thing which COVID pandemic has done is forced us to think in a different way in terms of, I think major issue had been the technological adaptation at multiple levels, specifically maybe from doctors, administrators. But COVID has given us the good chance for as a healthcare administrator to push for it. Like I think this will be a golden opportunity for us to change from our initial way of working to the new way. It has its tremendous benefits in terms of way. I always believe that which can make or change the healthcare system is the IT. So whatever way the things are managed as of now, that's gonna change tremendously in terms of it will impact your cost optimization, resource utilization, and how we are interacting with the patient. That whole system is going to be changed with the IT. So this can be a golden opportunity for most of the hospitals to use it, and good ways like the consultants are very friendly for that. Let's try it, like because they reduce their work to maybe less than half, and they will be very much. They will have also time to give some inputs. So for us, if you specifically ask, we started. Everyone started with our teleconsulting and all. We started with our OPD EMR. So this project was pending with us for maybe I guess for more than 3 4 years, but recently we started, and last couple of months back we went live, and most of our consultants are now on the OPD EMR system. So and that has helped. And sometimes what happens, like there are some hidden values. Once you start using it, then only you realize that there are certain things which were not visible before, and now those things are coming up. So those are very like always you believe certain things like ये हो रहा होगा ऐसा हो रहा होगा, but this gives very real picture in terms of how we are managing. But for us, this has helped us to breaking that barrier from the consultant or the administrators. Everyone is slightly reluctant in the way like the previous thing is working well, so why we need to do this? But right now there is no previous thing, so we can start on a blank slate. Like चलो ये तो है ही नहीं अभी तो ऐसे ही काम करना है. And we used all these safety measures in terms of, because we wanted everything to be untouched, no touch policy. So we said you have to integrate your technology starting from registration and everything. Then we have to make some apps, we have to make QR codes for patient registration. That patient has to scan their code, enter their details. It started with that because initially there was a lot of reluctance. Pen and paper, patient used to come, fill the form, give it for registration. So all things is now changed into the automated part of it, thanks to COVID in a different way in terms of making us believe that you have to have that no touch policy, and which can be easily interlinked with the technological adaptation. Like so, for us it is helping a lot, and I think this can be good opportunity for all our healthcare workers. As a team leader, you can push it right. This is the right time to push for it, experiment it. Whatever things are working well, go ahead with those.
Yeah. Thank you very much, Dr. Prashant, for sharing that. In a way, COVID has flipped the use of technology, which many of the administration must have been in their plans to integrate,
Yeah,
but there was a reluctance. May,
true.
yeah, Mr. Shah, we would like to hear. You have a chain of hospitals, Shalvi hospitals. So, to what extent the integration of technology has happened, and it also helped in rationalizing the cost in terms of delivering the health services, and how do you look at it in the future?
No, I think it is very important, and we have realized that information technology is going to control not only healthcare but particularly any business that we really talk about, and healthcare is no different. So we recently have started the implementation of SAP as a ERP for our group. We have implemented a very sophisticated hospital information system across our group, and we are also bringing in other technologies like CRM, etc. So as to kind of make sure that we are not leaving any loophole. And also, like what Pratik mentioned, we are also essentially working on EMR in a big way. In fact, even video consultations, the kind of consultants that we saw, like that I personally saw within our hospital group, being ready to do and being ready to take video consultations. I never imagined them doing that ever. So from that perspective, we have really in these last 6 months, it's as good as we have moved 6 years in terms of technology. So I think that is the best and the most astonishing part about what has happened, and which is what we are trying to do across the system. So of course, there are a lot of executional issues when it comes to that, because when you talk about making a paperless system, it's not just doctors. It's you have to basically make sure that your flows are also kind of paperless, your operating theaters paperless, your wards are paperless, everything has to be paperless. That is exactly what we are working on, and the target is that in the next 12 months we'll be able to get where we want to be. You're on mute, Sudhir.
Thank you, Mr. Shah. Pratik, I come to you as Mr. Shah mentioned that he did not imagine his staff members, his colleagues to adapt that video consultation. So it is also about the staff of the hospital healthcare system taking these, adapting these technology and working with the technology. On the other hand, it is those who are receiving the healthcare services. So what is that you looked at on the behavioral front of both the staff and also on the front of those who are receiving the health services?
Right, right. No, it's a very valid point. I think we've ourselves faced difficulties. I think the adoption has been much more easier in tier one in metro cities, where both the patient and the doctor is still a little more inclined towards these systems. And however, we operate in very small cities. So, for example, we have a setup in Kashipur, which has a very small population. To ask a doctor there to consult a patient via video, it involves a different set of challenges. But I think the important bit that I think everyone has realized over the course of this 6 months is that this is something which will be a part of the system going forward. Uh, Whether it's an enabler or the main force acting as the point of touch, it will be one of the access points which patients will access in order to get healthcare facilities. And I think it's important to embrace it in a similar way. What we have seen personally is that initially during COVID, we started a teleconsultation platform, and we are still building that platform to make it much more coherent and much more exclusive, adding various other features. But initially, after the pandemic struck, we started doing teleconsultations, and the numbers were substantial. We were doing across around 15 to 20,000 consultations per month across 13 hospitals. And of course, that number has come down subsequently as people have started coming to OPDs. However, what people and doctors have realized that certain kind of care, certain special departments can easily be accessed via telemedicine, and something like a follow-up, which is prescribed almost at every hospital but is hardly done, can easily be done through a teleconsultation system, where rather than having the patient to come back and follow up, it can easily be done through a platform which ensures that the small checks and balances are maintained. So I think we have seen an evolution of both the patient as well as the doctor. Initially, it had been difficult, but the I think the idea is to have a platform which is seamless and ensures that it's easier to access both the patient and the doctor. And I think this will be an important part going forward for all hospital systems.
Thanks for sharing those experiences, Pratik. Dr. Prashant, I would come to you. How is this interaction, as Mr. Pratik mentioned about the evolution of how the patient takes it, and how also the healthcare management takes it. These consultations, telemedicine consultation, and what has been your experience on this front?
Yeah. So one thing which helped us is there is no kind of reluctance, or there is no kind of why it is needed, or main thing what happens is the alternative. So we always seen that there is no other alternative for us to do this. Like if you talk to the patient, like you have to talk to the doctor, then there is only one option, that you can talk only on phone. So that has helped during this period, because there is no other option which might be easier, perceived better, but there was no alternative kind of for the patient, because they are not able to travel. They are not traveling. The hospitals, most of the places, there was a lockdown. So whole ecosystem around it was kind of nourishing whole system of teleconsulting and all. But as things evolved, we have to capture the good things and the good feedback around the teleconsultation, which you might have got. And on that only we have to build, because one thing which has helped is to give us some sample or some pilot where we could run those telemedicine and all those things which couldn't have been at any time. So there will be some consultant, maybe a 10-20% consultant, who are now inclined to start teleconsultation for some remote places and all. Now you have to strategize yourself as a hospital, that where you can fit in into those segment in terms of what is your outreach, which segment can be your target for this teleconsultation and telemedicine. And for the doctors also, who are more tech savvy and who could optimize the utilization of that technology. And that last 4 or 5 months given us some sample for it to understand the real sense how it works and what benefits can pass on to the patient. So that has been the key. But for routine patients, I believe like you will not be continue with the same kind of vigor and energy by the patient. If they have an option to visit the doctor without too much of headache, they will prefer that instead of going for a teleconsult or telemedicine. Yeah, so we have to explore that segment of population who might not have access, or they might not be easy for them to go ahead with that consultation. For us, it has given a good sample as a pilot, which we can optimize and utilize to strategize ourselves how we can project in that.
Great, absolutely right. Many of the patients also feel satisfied. There is something called satisfaction, and there is something also called kind of trust. There is also something also called as doctor's touch, the human touch. So I just wanted to have a rapid question with all of you. What is the level of the percentage that you're looking at the integration and the investments by your management? Am I audible, Dr. Prashant? So I would like to go for a quick rapid question to all of you. What would be the extent of rationalizing technology in the coming days, and your investments in use of the cost-effective technology to deliver further services to the patients? And how do you look at it as a revenue stream? I'll start with Dr. Prashant.
Yeah, means definitely I think it helped us to justify, because we also have to convince our board or the investors in terms of what kind of investment we want to do. We always have a limited fund, but this definitely is a priority now, because nobody has that kind of notion in terms of we don't know about this thing and how to manage those points. But right now that has helped us a lot in terms of getting that go ahead. Yeah. So particularly if you ask for us, we want to now use this opportunity and try to go paperless for our hospital in 2 year down the line. We started with OPD. We in the coming year we want to go for IPD. So only thing is in terms of investing, there is always reluctance for the significant cost to be incurred. So we are using our existing solutions as far as possible, but definitely we have a good plan of maybe few lakhs up to a crore to be invested into these kind of solutions.
Yeah, thank you very much, Dr. Prashant. There was a technical hitch. Dr. Shah, Mr. Shah, we would like to hear from you the quick question on your the investments and the possible plans with the integration of rationalizing technology to further the healthcare services. Mr. Shah, am I audible to you? Meanwhile, till Mr. Shah would connect with us, I would request Mr. Prateek
Sure.
to give your take on that.
Yeah, so I think the way we are looking at technology for our organization is at two fronts, as a revenue stream, but also as a system to ensure more efficiencies within the existing hospitals. So, as a revenue stream, my personal opinion is that at least in the next 2 to 3 years, telemedicine and teleconsultation will act more as a conversion medium rather than a sole segment itself, because currently to be profitable and to generate enough revenues from telemedicine, the volumes needed are very high, because the revenue structure is in such a way that it won't be possible vis-a-vis the cost of acquiring a patient. So if you look at it purely in economical terms, telemedicine might not be a segment, at least in the short term, which will be profitable on its own. But the way we and other hospital players, even health tech players, are looking at telemedicine is to use it as a conversion medium. And for example, in hospitals, we track an OP to IP conversion, which is one of the main indicators of a performance. The way we would look at telemedicine is also in a similar way and see the conversion from telemedicine to OPD and then finally to IPD. It will drive more pharmacies, it will drive more investigations, it will drive new patients to our existing healthcare system. So, as a means of conversion, I think telemedicine will do a good job in the next 2 to 3 years. Maybe in the long term, in the 4 to 5 years, it might become a segment which is profitable on its own. But for the time being, we are looking at it purely in terms of a conversion medium. The second is to look at the efficiencies that are there in the system. So EMR is something that we are implementing across all hospitals, because the data that is generated, we are making and taking real-time decisions now. So we have our MISs, we have our data that is being brought to us on a daily basis for all units. In fact, it is even more important for a chain, because we have locations which are very different, hospitals which are different in departments, and the functionalities are different as well. In that sense, using EMR, getting the live data on a daily basis and making those decisions immediately have a big impact on operations of the hospital. So I think in these two contexts, we are looking to spend some amount. Again, it's dependent on the number of beds, the number of hospitals that we are currently at, but it is certainly a big focus for us. In fact, we are building a platform currently with the idea to provide multiple access points to patients. So currently, patients only come to us as walk-in OPD patients or as a hospital network. But to have that additional system of telemedicine, of pharmacy, or even of chronic care, then the idea would be to provide these multiple access points and ensure that the patient has a continuum of care. They can come to us for literally anything, because the hospital sits at the center, but the other access points is something that we're looking to build, and that is something we're working on currently to build a healthcare platform on those lines.
What are the other access points you're building at or looking at, Mr. Prateek?
Sure. So we are currently located in mostly tier 2 cities. I think where the potential is still very large, because most of the chains, the big corporate chains, are still currently in tier 1 cities, and we are in northern India. And
Yeah.
so we have the hospitals at the center of these cities. but there are villages, there are blocks surrounding these hospitals. We have created primary care clinics through our NGOs, which can act as feeders to the hospitals. That is one access point. The other access point is through telemedicine, not just have the existing patients who are coming in to us through the referral system, through doctors, but to have a new sort of system where patients can feel accessible at any location, especially in a tier 2 framework where not everyone is comfortable. Probably they want to go to a tier 1 city, probably they want to travel and take that chance. But with COVID, we have realized people want closer care, they want remote care, and it works well for certain departments. And once you have your patient in these access points, to provide that continuum, whether it's from a clinic to a telemedicine point of view, to ultimately tertiary care, which is what we are mainly doing, tertiary and quaternary care. I think that entire ecosystem is very essential, and I think that will be the model that will drive future healthcare systems, to not just provide one point of system, but to ensure that the patient can come through any of those systems and be interchangeable.
Wonderful, amazing knowing the plans, Mr. Pratik. So that was Mr. Pratik Ghoshal, who's the Chief Strategy Officer with Ujala Signals Healthcare, and we have come to know about their plans, how they are looking at things in the tier 2 cities. So with this, there is a lot to discuss actually, but we would like to end this particular session here. It has been amazing. This is the last session of the day 2 of the second edition of Global India Healthcare Conclave. Over these 2 days, we had an amazing congregation of speakers from the policymakers from Government of India and various state governments, Kerala, Tamil Nadu, Uttarakhand, and various other the state governments who are the policymakers. And we also have come across various interesting sessions who were the decision makers with the hospital managements, who were the chief executive officers and MDs with various healthcare system, and also those who have been providing the technology in this healthcare system. With this, I would like to thank all our eminent panelists. It has been amazing experience, enriching. So with this, I would like to thank Dr. Prashant Deshmukh, who's the COO of SIMS Hospital. Thank you very much, Dr. Prashant, for joining us once again.
Thanks.
And Mr. Shah, if you can hear us, Mr. Shani Shah, who's the president, Shalvi Hospitals. Thank you very much for sharing your insights and your plans and those uh, deep insights regarding this particular session on cost management. And also, Pratik, glad to hear from you. Uh, uh, it's been an amazing session and interesting session. Thank you very much for joining us. We would soon meet in our upcoming editions. Thank you very much.
Thank you.
Thanks. Good day.
Good day.